Thank you very much for the opportunity to speak. I'll try to get through this quickly because I know we're running behind, but I want to give you a bit about the US perspective, but talking about how we can use Telederm really for triage to optimize access to care in the US. So here are my disclosures, none of which are particularly relevant to this talk. I want you to think back to how you felt in March 2020 and think about that panicked moment. This doctor here who's probably doing telemedicine for maybe one of the first times. And think about how we all felt at that time, but think about how COVID-19 really brought to the forefront teledermatology as a way to connect with our patients in a way that we really hadn't capitalized on before. And this pandemic brought about overnight, essentially what many of us were trying for years to bring about through standard means of change. But now we have the opportunity to reimagine what teledermatology looks like post-pandemic. What do we want this technology to be rather than something that was sort of forced upon us in a moment of panic? So I think we can really use this to expand access, to reach the patients who need us the most, to optimize triage so that we avoid inappropriate treatment by those who are waiting, who are seeing non-dermatologists. And also we can use it as a tool to combat burnout. So that's a huge problem in the US physician population is burnout. So can we actually combine teledermatology with AI to help us out, to make medicine less burdensome? So I want to, as the outgoing chair of the Teledermatology Committee for the AAD, I want to point you to, we have updated online teaching modules. So if you're not familiar with Telederm, which I imagine that it's not the case for this crowd, we have a whole set of teachings that are about making teledermatology work for you. This is for AAD members, but it's really about guiding your patients, training your staff, avoiding common pitfalls, and sort of making dermatology work. There's also some information about how to accurately code these encounters. This is a moving target, so this thing has to constantly be updated, which is very difficult for the AAD to even keep up with because the rules are constantly changing, and we're actually now up against a deadline again at the end of March. So we'll talk about expanding access, reaching the patients who need the most. We know there's this huge chasm between us and the patients who need us, but telemedicine can address that by making us more efficient, to expand our capacity and actually make care more convenient, both for the practitioners as well as for the patients. And I think we've learned this through the course of the last 5 years. Patients like this, physicians actually generally like it if they give it a try. Virtual care also has the capacity to improve access to specialists like us for marginalized groups. This is a huge problem in the US where we have massive healthcare disparities that make people in rural communities, people experiencing poverty, racial and ethnic minorities, folks with disabilities and incarcerated persons way less able to access us as specialists. So as the specialists who are best able to care for skin disease, shouldn't we be leveraging telemedicine technology to reach these underserved populations to build a bridge across that gap? So as you know, it was presented in other slides, the US is actually a huge country, right? And we have these same issues that other countries face. We have a lot of people that are concentrated in very urban areas, but you have all these people in more rural areas that really don't have access to specialists. But teledermatology really can bridge that gap, right? It brings the patient into our office no matter where they're sitting. And this has been shown in a number of different programs in the US. Direct-to-patient teledermatology can bring teledermatology to rural patients, even those who lack broadband internet, right? You don't have to have a super fast or stable connection if you're going to do store and forward, for example. One of the things that has happened in the coding and billing landscape in the US, CMS has now determined that live video is not required as long as the patient either is unable or unwilling to do live video chat. So that's something that I think could open it up to patients who maybe don't have access to the technology or in an area where just live video is not feasible because of their poor internet access. Provider-to-provider e-consults have been a real win, I think. It's just that they're undervalued in our system. So if we can take the power of store and forward, which the quality of the photos you get in a still photo is much, much better generally than video at this point, this can actually be a great tool to increase our outreach. But we need to bolster reimbursement in the US because this is not paid very well. It can actually be effectively combined with an audio-only encounter so that you can have the person on the phone and review the photos that are good quality. And that can actually be a game changer as long as it can be coded as a regular E&M, right? So that's the game changer in the US. Local PCP offices and public libraries might actually help us to reach underserved populations. That was mentioned in one of the prior talks. When patients don't have access to the type of equipment that they need for a successful telemedicine encounter, can we partner with our community or public resources to bring that technology to them? I want to talk about an economic argument for this as well, because if you don't make an economic argument, I think there's not going to be uptake, as we heard from some of our earlier speakers. But teledermatology can actually reduce the no-show rate, which is a win for all of us, right? So if you're sitting in your office and you're there, you want your schedule to be filled. Telemedicine can actually reduce no-show rates for many different patient populations, as shown in the blue bars versus the gray bars there. People show up for teledermatology, which is a wonderful thing. Sometimes they're driving in their car during the appointment, but they show up for it, okay? So, but I think it's important for us to remember about underserved populations. Why might they not be showing up for appointments? There may be difficulties with transportation. You might not have access to childcare. Your work schedule might not be as flexible as some other folks. So we need to keep these disparities in mind when we're making rules about how telemedicine can be implemented in a country like the US. And then also, if we're doing everything through portals, if patients have to log in, have an email, get online, think about who's not using those portals and why not. So many marginalized groups in the US don't have access to these portals or don't have the level of literacy to get onto them, but they've also had lower odds of actually being offered portal access because we might make assumptions about someone's abilities or understanding of technology. This is sort of called the digital divide in the US, where we talk about people who are connected and people who aren't as connected. And there are many barriers that are out there that can keep patients from accessing this in ways that can allow them to get care. This is really important for us to address. If they don't have the devices, how in the world are we ever going to build this bridge? I want to talk briefly about optimizing triage. So who's next in line? We all know that we have these very long lines of patients waiting to see dermatologists in the US. Is it a first come, first served system? Is that actually the best way? Who tends to get added on? It's often the squeaky wheel, we call it, where the person just keeps calling and nagging you. Oftentimes it's the worried well, people who are actually totally fine, but really, really want to see us. People who are well connected or VIPs, they're often jumping the line to get to see us, but shouldn't it be that we see first the most urgent diagnosis and the highest risk patients? So in this line of people waiting for us, how can we use teletriage to actually say, well, the person who happens to be at the front of the line just has a seborrheic keratosis, whereas way further back in the line is someone with a melanoma or pemphigus that really merits a sooner visit. So we've done this in our outreach clinic, where instead of allowing primary care providers to decide who comes to see us in person, we took away that pathway from them and said, we want you to do a teletriage encounter first. Let the dermatologist who has the expertise actually make the decision and decide who really needs to see us and who can be managed remotely. This allowed us to actually introduce an interim plan. Even if patients needed to see us in person, we could sort of start the workup and the treatment while they were waiting. This actually reduced time to specialist input, and this is actually a really good case scenario where it was taking about 2 weeks for patients to see us. We could get an answer back to them within a day and a half through teletriage, which is great, and it can be even shorter than that. So if you get pictures like this, you can make a pretty easy diagnosis, something like acne keloidalis or basic hand dermatitis. And we showed that for many of these eruptions, you can get a definitive plan without actually seeing the person in your office. 2/3 of cases, and this is borne out in a lot of other studies as well, about 2/3 could be triaged without needing to see us. Of course, this differs whether we're dealing with a growth, a neoplasm, versus something like a rash. We're much better at diagnosing and managing rashes. We're more comfortable with that than something that could be malignant. But this allows us to open up more open appointments for new patients to basically deal with this constant line that we have. The other thing is that specialist input matters. We looked at, like, did we actually change what the PCP would have done if they didn't have access to us in this way? 90% of the plans were changed. 76% were a complete change, and another 14% we tweaked their plan. So it's really important that we do this so that we start with the right approach, that we avoid antibiotic overuse or ER referrals, and that we actually accelerate the workup for these patients who really need to see us. Finally, I want to just briefly talk about burnout, which is a huge thing in the US population of physicians. This is a huge public health issue, I think, because people are actively dropping out of the medical workforce, which is going to worsen shortages. Telemedicine can contribute to burnout. It's extra training for your clinicians and staff. There are often inappropriate referrals for telemedicine that just isn't suitable for it. Maybe the patient's not prepared. I think we've all had things like this come through where, like, someone sends an image, there's all this distracting background. It looks like they went into a cave to take a picture of their skin. Or this, where like don't have the video and you have to explain to people time and time again how to unmute their camera, right? So these can be frustrating things that can actually make things worse, but it can also reduce burnout. Think about how nice it is to be able to be flexible in where you work from. It changes the pace, it changes the scenery. It also allows for scheduling flexibilities for people who have care responsibilities for family members. It can actually help us to salvage missed clinics. If we have car trouble or can't get there, or our staff has to call out because of illness, could we still have a virtual clinic using telemedicine? And as I mentioned earlier, it can actually reduce no-show appointments, which are frustrating for everyone. Finally, combining AI with triage, teletriage, I think, could be really important. So using chatbots to actually screen people for telemedicine. Is this an appropriate encounter for virtual care? Or if not, schedule an in-office visit. Can they actually collect the data beforehand to make our visits more efficient? That would be great. And then finally, just make it work better for us. Remind patients of their appointment time. Give them an easy link to click so they can get into the clinic appointment very easily. Using this to actually test the thing beforehand. We talked about taking a picture of a check, right? If we can get these sort of things moved into the teledermatology space, it could make our encounters much more efficient and effective for patients. So reminding patients to take photos, helping them take better photos so that we can be better equipped to help take care of them. So in summary, the pandemic really required us to rapidly adopt telemedicine, but now we have the chance to redefine how it's done and how to make it actually work for us. We can actually build this bridge in a way that makes sense. It can make our practices more efficient, but we've got to select optimal cases, stable patients, refills, things like this. But we also have to think about how this can be used to actually increase access for underserved patients, which is a huge problem in the US. But then on the bigger eye picture, we need to think about systemic level changes that can actually make telemedicine sustainable beyond just this sort of kicking the can down the road every 3 months with the budget in the US. So this is really important. And then finally, embracing AI in a cautious way to implement it in a way that's secure, safe, and actually helps with equity, I think is really an opportunity to use technology to make care better in this country. So thanks very much. I want to thank the students who contributed to the research that I presented, as well as our partnerships that have helped us to do some of the telemedicine that we've done. So thanks for your attention.